So good evening, all the aspirants. It was worth the wait. The topic for today is CRRT in ICU. Our organizers are Dr. Akhilesh Tandekar, Dr. Gunadhar Padi, Dr. Asif Iqbal, and the speaker that we have here today is Dr. Ranajit Chatterjee, who is the HOD in Critical Care Swami Dayanand Hospital, Delhi. Thank you, sir, for being with us. You can start your class.
Good evening, everyone. I think people are still in the process of joining, and I am Dr. Chatterjee, and I'm will be talking about the continuous form of the renal replacement therapy in the ICU today. Uh, the continuous form of renal replacement therapy has taken a revolutionizing step over the last years. See, we started this last 15 years back in one of my patients. It was an old model of the Prisma machine. The patient was suffering from severe AKI, along with ARDS, along with severe metabolic acidosis, fluid overload. After a simple cesarean section, the patient went into that. And now, after 7 days of CRRT, she was weaned off from the ventilator, and she is now happily living a life along with her 80 years old child. So from there, we went to the newer type of machines, which started coming like this. This is the next generation of machines came, and we started well acquainted with us. This is the ECOR going on, extracorporeal membrane oxygenation, along with this. And, and by the time we came up with the third form of machine, that is the latest generation of machines, the Prismax, from a particular company that came up. The other franchises are also coming up with the newer machines. So this is the generation over the last 15 years that we have seen in the change and the trend, how it has developed. I still remember 15 years back when it started, 15, 20 years back, people don't used to know exactly what it is. Now everybody knows about the continuous form of renal replacement therapy, especially our young generation who are coming up as DND students, the edic students, the young consultants. We are really feeling good for that. And it's a great thing that we are using this in many of our patients to save their lives. So this was started by Johann Kopf way back in 1943. He's the father of dialysis. We should always remember him. He started with the washing machine, the the motor of the washing machine, the sausage skins, and the orange cans. That was the first used in 1943. From there today, this was the first machine that he was using with one of his patients in 1946. He went on doing the renal replacement for this dialysis for around 16 hours, unknowingly knowing that he's doing it for the first time. He's doing it. He's doing his procedure is basically a sustained low efficiency daily dialysis that he was doing. So this renaissance that has taken place over the last 60 years is really an eye opener for us in how we are progressing in the medical science. So if I classify CRRT, normally, first of all, I'll explain you what exactly renal replacement therapy is, and from there we'll take up certain questions, and according to the questions, I'll take it forward. So renal replacement therapy will be two types. One is intermittent, another is continuous. The intermittent type is intermittent hemodialysis, which is the most popular form. Sustained low efficiency daily dialysis, the hybrid type of therapy, neither continuous nor intermittent. In between is a prolonged intermittent type of therapy, peritoneal dialysis. Whereas continuous form is different types: slow continuous ultrafiltration, continuous veno-venous hemodialysis, continuous veno-venous hemofiltration, and continuous veno-venous hemodiafiltration. When you are doing a continuous form of this therapy, normally we put a catheter in a vein and we take out the blood from the vein and push it in the same vein. This happened since 1990s. Before that, it was basically arteriovenous. And now it is a veno-venous form of therapy that we do in the continuous form. So this was the first definition given by the three stalwarts, Milamo, Ronco, and Mehta, way back in 1996, that any extracorporeal blood purification therapy intended to substitute for impaired renal function over an extended period of time and applied for or aimed at applied for 24 hours a day. And the principle by which it works is the diffusion, ultrafiltration, convection, and absorption. Now, diffusion is mainly used in dialysis. It is the movement of solutes from higher concentration to lower concentration across a semi-permeable membrane. Now, here what happens? Only the small molecules are removed. Urea, creatinine, bicarbonate, sodium, potassium, these are removed by diffusion, very well removed by diffusion. It's a dialectic process. Ultrafiltration is the movement of fluid across a membrane, semi-permeable membrane against a pressure gradient. Diffusion is against concentration gradient. Ultrafiltration is against pressure gradient. Along with this fluid, the lot of solutes are also drawn. So the solutes and solvents are moving together. This is known as solvent drag, and this is convection. So I'm removing a lot of fluid along with the solutes that are being removed by ultrafiltration. And here, not only the small molecules, but also the middle molecules are also removed. The absorption is basically the absorption is the molecular adherence to the surface of the membrane. So some molecules get adhered. So diffusion, ultrafiltration, convection, and absorption. These are basically the four methods that we used in the dialectic process. And we basically are going to see how it differs when we take the different modalities. So the first question comes, which modality? Intermittent modality or continuous modality? Now see, if you see whether intermittent modality, as I told you, is mainly diffusion, and continuous modality is mainly working on the basis of convection, which is not used in the intermittent modality in intermittent hemodialysis. So the human kidney works convectively. Our kidneys work convectively. So it is more physiological and it works very slowly. And so diffusion, whereas removes only the small molecules, here the middle and the higher molecules are also removed. And it gives, as it is a slow process, so it gives more hemodynamic stability and less osmolar shifts among the compartments. So this is the advantage of a slow process. Now, if I compare these three, which is basically that comes always in our mind, whether it is CRRT or it is intermittent hemodialysis or SLED, if I punch it into one slide, I'll find that CRRT is more physiological because it works by the process of convection. Now, whenever my kidney is failing, and that to an acute kidney injury, in the or I am having a fluid overload, or having a metabolic acidosis, I always will intake initial stages to give a 24 hours support, not a half-hearted support for 12 hours or a 3 hours support. I'll not allow my kidneys to go unlooked for or unattended for, and I'll try to give them a support for 24 hours. As I told you, that there is no rapid intercompartmental shifts because of slow, it is slow and smooth. That gives it the hemodynamic stability. We have very good papers and very good idea about the dosing of CRRT, which is missing with SLED and IHD in patients who are acutely ill. And the effective volume removal, this is very important. This drop by drop volume removal and replacement of it is done by the continuous therapies. The middle molecules are removed. That helps in the management of sepsis, and it is excellent in patients of cerebral and pulmonary edema and hepatic encephalopathy. And certain observational studies have shown that it might be helpful in renal recovery when compared to ISD or SLED. Now, if I compare these two, so that is the reason why I don't compare. Basically, it is comparison between an orange and an apple. So CRRT is the sickest of the sick. I'm not telling to use CRRT in all the patients, but in the sickest of the sick, where the patients is hemodynamically unstable, multiple vasopressor therapies, there I start CRRT. And in SLED, I use them in transition. Once the patient improves, I shift from CRRT to SLED. So see the dose that has been used in SLED or SLED-F. SLED-F is sustained low efficiency daily dialysis with some amount of ultrafiltration. The dose is by KT by V, that is the removal and KT by V of urea. That is how much the urea is removed and the volume of distribution is taken into account. Now you tell me a patient coming for intermittent hemodialysis in his car, coming having a cup of coffee, reading a newspaper, and the intermittent hemodialysis is done. He's a stable patient. It is compared to a patient who's on a stretcher, on multiple vasopressors, on ventilator, where you are not sure about the volume of distribution. That is the main problem. This this will you somebody please stop talking behind? Will you please stop? Will you please unmute yourself? It's very really disturbing. So if this volume of distribution is basically not known to us, That is the problem. Because we are not sure, the patient may be volume overloaded, the patient may be volume depleted, the patient is on multiple vasopressors, so there is a metabolic instability. There is maybe some residual renal functions which is still present in these type of patients. So that is the reason we do not take this volume of distribution in our dose. That is the reason the effluent volume, that is the volume which is collected in the bag by dialysis and ultrafiltration, is considered as the dose of CRRT. So CRRT is used especially in hemodynamically unstable patients, where we can go for precise volume control, immediately adaptable to the changing circumstances. And these situations, it is very effective control on uremia and potassium, increased potassium, there is hyperkalemia, rapid control of metabolic acidosis, fantastic in brain injuries, directed resistance, pulmonary edema, cerebral edema, and definitely with the middle removal of the middle molecules may have some adjuvant effect in the treatment of sepsis. And definitely, it is an advantage in terms of renal recovery when if the observational studies is taken into account. So it is not renal replacement. This is from renal replacement to renal support. In fact, I say organ support. So you have certain life-threatening indications like hyperkalemia, acidemia, pulmonary edema, uremic complications. These are life-threatening indications in a backdrop of a hemodynamic compromise. You can go for a solute control, the fluid removal, the acid-base electrolyte imbalances. For a renal support, not only the acute kidney injury you are supporting, but you're taking care of the nutrition, the huge volume that is being given to the patient, the fluid removal in congestive heart failure, in pulmonary edema, in cerebral edema, in cytokine management in sepsis, especially respiratory acidosis in ARDS, where we use ECOR along with CRRT, and the fluid management in multiple organ failure. Just certain novel indications, like it has been used especially to replenish bicarbonate in special of alphos poisoning, or CRRT causes a lot of hypothermia. So it is used sometimes in refractory hyperthermia. Electrolyte abnormalities. You have to change your fluid management, the composition of your fluid to manage hyperkalemia, dysnitremias, and hypercalcemia. And in crush syndrome and tuberculosis syndrome, CRRT has been found to be effective. So it is not a form of continuous renal replacement therapy. It basically supports all the organs, whether it's the brain, the liver, the lungs, the heart, the intestines. So we can say that CRRT, the continuous renal replacement therapy, can be easily recoined as continuous organ support therapy. So that what CRRT is. Now, in CRRT, which modality? If you have selected that I have to use a continuous form of therapy, now which modality you want to choose? This is the next question that comes. So you see, when you are doing hemodialysis, the blood is entering the circuit and the fluid is going on the other side. So there is a counter current mechanism. Small molecules are removed. This is hemodialysis. Moment you do hemofiltration, along with the small molecules and the middle molecules, a lot of fluid is removed. So if you remove that amount of extra fluid from the patient, you also replace it back to the patient. So that is the replacement solution that is being used. If you combine both of them, it becomes hemodiafiltration. Hemodialysis, hemofiltration, hemodiafiltration. Accordingly, slow continuous ultrafiltration, where you only remove the extra amount of fluid from the patient. Continuous venomous hemodialysis that I told you, continuous venomous hemofiltration, and hemodiafiltration. Now, suppose you want to remove only the volume from the patient, cerebral edema, in pulmonary edema, that extra amount of volume you want to remove in congestive heart failure. So you take up slow continuous ultrafiltration. Now you want to remove some amount of solutes also from the patient. So you can use continuous hemodialysis hemofiltration, or suppose you want to only replace the bicarbonate, use hemodialysis. You only want to replace exchange the potassium, or you want to take out the extra amount of creatinine from the patients, use hemodialysis. But in a sepsis patients, or where the patient is having multiple problems, there I select with continuous venomous hemodiafiltration. The modality changes according to the situation of the patient. So once I have selected by therapy, once I have selected by modality, now I'm going to start by CRRT. So the first question comes, where to insert the catheter? The catheter, the best place is the right internal jugular vein. And the next one is the right femoral. The problem is, most of the times when you are starting CRRT, you already have a CBP line in place in the right internal jugular. So many a time by default, it comes the right femoral where we place our catheter. You have to put it by ultrasound guidance. Remember, different Frenches of catheter are there. So around 11 to 12 French of catheter is enough to bear a flow of around 300 ml per minute of blood flow. If you should be aware of recirculation inside the catheter. So in femoral catheter, you should place it at least 20 centimeter inside. These are special catheters that are available in the market. So if you put a 15 centimeter catheter in the femoral, so the quality of CRRT will decrease. Why right internal jugular is good? Because you have a pool of blood in the form of right atrium. When you put a catheter there, the flow is very good. Remember, if the catheter is put wrongly, then your CRRT machine will stop automatically. The filter will clot. So it is the catheter which is the most important part of CRRT when it is initiated. So if you don't put a catheter properly, your CRRT will not run properly. So once you have put your catheter, now you should know that I have to when I start my CRRT and I'm using a hemofiltration, I have to some replacement solution that I told you. That I'm removing that extra amount of fluid from the patient. So what to replace? Where to replace? So what to replace? We normally replace bicarbonate-based fluids to the patient rather than lactate-based fluids. So this is the KEDICO guideline, though pretty old, but still it is continuing and we are following this. It is used in patients with AKI, in patients with AKI and circulatory shock, and in patients with AKI and liver failure and lactic acidemia. Basically, the fluids which are used are bicarbonate based. Now, where to replace this fluid? So there are two types. It may be pre-dilution or post-dilution. Pre-dilution means once the blood is entering the filter, you are replacing the fluid before it enters the filter. So if you are replacing that amount of fluid before it enters the filter, so what happens? You are diluting the blood. So if you are diluting the blood, so you are compromising on your confection, but your clotting risk of clotting of the catheter of your filter decreases. But once you put it in post dilution, your better convection is there, but you have to use more anticoagulant to basically preserve your filter. So where should I replace pre or post? So normally we replace 1/3 pre, 2/3 post. There is no such hard and fast rule. If we are using citrate as an anticoagulant, then it is only used in pre-dilution. So the huge amount of fluid is used in pre-dilution when you are using citrate as anticoagulant. Now, what filter you are going to use. So if you see the anatomy of the hemofilter, you will find that there are different hollow fiber membranes through which the blood flows, and around the hollow fiber membrane outside the filter, the effluent flows. It looks like this. Initially, it started with unfortified cellulose. Slowly, you have moved on to synthetic membranes, which are least incompatible. They are having very good absorptive surface, fantastic surface area, and very big pore sizes, so that the pores are not getting blocked. Remember, if you are having a sudden hypotension following the use of these filters, when you start the CRRT, there is a lot of bradykinin is released. There is sudden hypotension, pulmonary congestion, pulmonary edema, especially in uncoated AN69 membranes, patient with severe metabolic acidosis, patient whose circuit is primed with a blank blood, patients on ACV inhibitors, and this can be neutralized by coating the AN69 membranes with polyethylenamide. So bradykinin release syndrome is a thing of the past because most of the filters that are coming, they are basically coated with polyethylenamide. Now, once you have started the CRRT, you have to decide on the anticoagulant. This is one of the disadvantages of CRRT because in SLED or in hemodialysis, you may continue even without anticoagulant. In CRRT also, you can continue without anticoagulant if you give intermittent saline flushes. But the normal anticoagulants that are used are either unfractionated heparin. Remember, you have to keep the APTT between 45 to 50 seconds. You have to measure every 6 hours the APTT. The dose is between 5 to 10 units per kg per hour. Low molecular weight heparin can be used, but the anticoagulant of choice nowadays in all over the world is the citrate. So I'm not going into the details of that because it will take another class to discuss citrate. And normally, if the patient is in over DIC, we do not use any anticoagulant. Shouldn't give intermittent saline flush. Unfractionated heparin can be a blessing in disguise in initial stages of DIC because when there's a lot of consumption of coagulation factors, unfractionated heparin may be useful during that time. But it should not be used if the patient is having heparin-induced thrombocytopenia or thrombocytopenia per se. See, citrate definitely is a choice when you're using DIC. It is a regional anticoagulant, but citrate enters the circulation and get converted into bicarbonate in the liver. So in acute liver failure patients, citrate has to be used with a point of caution. Citrate comes in the form of sodium citrate. So a lot of sodium is released. So there is chance of hyperkalemia here. And as you're chelating calcium, so you have to replace calcium here. Otherwise, you'll have hypocalcemia in your patients. So when to start CRRT? Once you have decided when to start CRRT. So there's a question: early RRT or later RRT? So this early and late are very relative terms. So if you see the classification, Rifle, Akin, or Kedigo, you will find that these stages, normally you all know about the stages where it is either classified in the form of creatinine or in the form of urine output. So Rifle also had GFR along with it, that was removed in the subsequent criteria of Akin and obviously the Kedigo. So if you see the from 2016 to 2021, you'll find 5 studies: the Alliance study, the Akikita study, the Ideal ICU trial, the Start AKI trial, and the Akiki2 trial. Except for the Alien trial, which was a single center trial. Most of the trials started in the third stage of the disease when the patient is having acute kidney injury. You will see that in the Alliance trial, the mortality in the 90 days, if you see a bit more in depth, you will see that it is in 39.3%. Whereas the mortality in all the trials when they started in Kedigo 3, it is somewhere around 50%. So there is a huge difference if you started a bit early, though it was a single center study, and most of the studies which started in either in the third stage, most of them found there is no mortality difference between early and late, but there is increase in the complications when you start it early. But there is no mortality difference. But if I compare the studies, I'll find that when it started in Kedigo 2 in the alien trial, the mortality was significantly less. It was 39.3%, below 40%. But when it started late, it it hovered around 50, 48%, 50%, 58%, like this. So this has to be taken into account. But when we start it, we always tell it is if the patient is having AKI or the patient is not having AKI. I'm telling repeatedly that renal replacement is not only for the kidneys. It is for different situations like refractory fluid overload, septic shock, ARDS, hypothermia, acute liver failure, severe electrolyte imbalance, acute tuberculosis syndrome. You start it immediately that time. But if the patient is having AKI, then at least try to optimize the volume, the mean arterial pressure, the cardiac output. Try to take care of your intra-abdominal pressure and see in which stage the patient is in. If the stage is stage 2 or can you go stage 3. Now, here, what we have added, what we have done, when the patient is in Kedigo stage 2, if the patient is having a worsening AKI, how do you know if it is worsening? We do a furosemide stress test. We give furosemide at the dose of 1 milligram per kg if the patient has not received furosemide before, or 1.5 milligram per kg if already the patient has received furosemide. And we see the urine output. If the urine output is more than 200 ml in 2 hours, that means this patient is not going to progress towards severe AKI. We do not start our renal replacement therapy. But if we find that the patient is not having that amount of urine output, that 200 ml, that means the patient might progress into severe AKI, that's Kedigo stage 3. So there we start our renal replacement therapy during that time. So we start. Along with that, if there is refractory fluid overload, it can go stage 2, severe sepsis, ARDS, or a hypercatabolic state, we don't wait. But if the patient is not having that, a stable patient, diabetic patient, sitting creatinine maybe is 4, 4.2, I'll not start. But the same patient on ventilator with lot of fluid overload, electrolyte imbalance, but it's getting go stage 2, we'll start. So it is the situation by which you have to decide when to start CRRT. Nobody can pinpoint you exactly start now. It is not possible. It has to be done by the bedside, and your experience will tell you exactly when to start CRRT. Now, when you have decided what dose you start, so this dosage has been cleared off by 2 trials. One is the ATN trial, and another is the renal trial. The one trial came out from USA, the other trial came out from Australia, and both of them have shown that the intensive or a higher dose of around 40 ml per kg has no advantage over the less intensive group around 25 ml per kg. So per hour, this is 40 ml per kg per hour, and 25 ml per kg per hour is the effluent volume that is being collected in the bag from the dialysate fluid and the replacement fluid and the ultrafiltration. So this is the dose. So the dose that KD was telling is that the effluent volume should be 20 to 25 ml per kg per hour for CRRT in AKI, but it has a lot of downtime. See, when you are starting your CRRT, if you start at 35, you may have certain stoppages like the nursing stoppages, the effluent bag change, the usual downtime. There is some technical downtime. So if you start at 35, you end at 26. If you start at 25, you end at 20. So basically, you have prescribe more to achieve what you want. That is the meaning. So if you want to target 25, you set 35 ml per kg per hour and divide this equally among your dialysate and ultrafiltrate. That is the prescription part, which is very difficult to explain here in this short time, but I'll try to tell as much as possible. Now, the dose. The dose is not so simple. 20 to 25 ml per kg per hour of effluent volume is a gross over or underestimation of the dose that has been used in CRRT. Those who are using it regularly, we know that the doses may be perfectly well for a patient who is having CRRT and AKI, especially in patient of AKI. The patient is having metabolic acidosis, fluid overload, dyselectrolytemia. Here, 20 to 25 ml per kg per hour of effluent volume is excellent. But if the patient is in acute brain injury, there I am going for slow continuous ultrafiltration. I will not remove more than 5 to 10 ml per kg per hour. And there is a significant crosstalk between the brains and the kidneys. And if I have to start a CVVH here, and the patient is having a lot of hypotension and on vasopressors, I'll start with a low ultrafiltration, maybe less than 13 ml per kg per hour. So whereas it's cough, I have to start early. I have to go for a lower blood flow. I might have to prime not with normal saline but with albumin. I have to keep a high dialysate sodium so the exchange takes place well. The fluid is being removed very well from the brains. Whereas if I move the same thing moves towards where the kidneys are injured, I start with a ultrafiltrate rate not at 20 to 25 here. At this present moment, I'm going for CVVH with severe hemodynamic instability. I might have to go for a lower ultrafiltration because it has been seen that if the ultrafiltration crosses 30 ml per kg per hour dose, there is again hypotension. Now, in case of acute liver failure, if the patient is hemodynamically stable, I have to slowly increase my dose up to 50 ml per kg per hour to remove that ammonia. The ammonia will not be removed at a dose of 20 to 25 ml. So this is the variation of dose that we are having in different forms of therapy. For example, you are going for ECOR. Here the blood flow have to go around 200 to 300 ml and have to put a neonatal oxygenator by the side of the machine here in the return line. And the oxygen is coming from the sweep gas flow is coming from the wall and the CO2 is getting exchanged. Now they're coming up with the sets which can be directly used in these machines. Now, when it is a sepsis, suppose you have AKI, fluid management, you have to see why you are using it in sepsis. For cytokine removal, definitely I have to go for a continuous venovenous hemofiltration. Metabolic control, let me go for hemodialysis. For it has been used for the improved energy balance. There I have to use certain special fluids where it can give some amount of energy to the patients. So this is beyond the scope of this lecture, but the variety of the doses it changes. The variety of prescription also changes according to the disease. Now you can add certain special therapies along with the CRRT. For example, the cytosorb, the toriamycin, the auxiliaris. There's the special filters that can be attached according to the situation of the patient. Though we have not have found any much mortality difference when you're using cytosorb or toriamycin or auxiliaris. Certain studies has been done, but they're not up to the level of our expectation. But still, we should go on trying them in the sickest of the sick patients. And we should come up with a registry. There is a registry, and we hope that some positive things come out in the near future. Now, when to wean, when to stop CRRT. Now, again, the KDIGO gives a very philosophical type of answer. Discontinue RRT when there is no longer required, either because of intrinsic kidney function is recovered to the point that it is adequate to meet the patient needs, or because RRT is no longer constituting the goals of care. The point is, when you don't understand anything, it gives this type of philosophical type of answer. So now this was 2012, that is to 2025. So we are now having much better, clearer option of this. So what we are doing, saying, if the urine output is increasing maybe above 400 ml per day, or the intradialytic urinary creatinine is decreasing. So that is the situation when we are trying to wean the patient from the CRRT. So the urine output is coming up, the creatinine level is coming down, the intradialytic creatinine, urinary creatinine is checked. So if these things has been seen to basically stop CRRT. So what about antibiotics and nutrition? Because this is a big question that comes up. So in this short time, only I can tell you those drugs which are having limited volume of distribution and small protein binding are cleared by CRRT. For example, mainly the colistin, the beta-lactam antibiotics, they'll be cleared completely by the CRRT. Even ticoplanin, though having a highest molecular weight, but still it is removed by CRRT. So we should not decrease at least the loading dose of the CRRT, and we should continue with this dosage at least for 48 hours still, and we go on checking our patients by doing regular procalcitonin levels, our cultures, and we have to decide on accordingly. If at all I have to change my maintenance dose, I have to create the creatinine clearance. Now the creatinine clearance, I give you a very simple formula. The dose, effluent dose, suppose the effluent dose is 30 ml per kg per hour. Your creatinine clearance is roughly around 30 ml per minute. So this you have to understand. So normally we do not change the doses. And if you see this chart that I've given you, if you see the beta lactams here, the first dose is increased, maybe up to double the dose. Then we give a continuous infusion, and daily dose of CRRT is unassisted. But for aminoglycosides, for glycopeptides, here we try to do a therapeutic drug monitoring. For vancomycin, we try to do a therapeutic drug monitoring. If you are having it, if you are not having it, then better to avoid. I always avoid those drugs which causes renal toxicity. We know that aminoglycosides are obligatory nephrotoxins. So if I have an alternative for that, so I'll use that. I know that vancomycin is obligatory nephrotoxin. So why should I go for it? Simple, very simple logic that for MRSA, I'll go for the other choices that we are having along with me. So I can use again linezolid, the dose remains unchanged. Colistin, you have to need a higher dose, maybe up to 12 million units, because most of this is removed. And this is antibiotics has to be managed very well in this type of patients. You should not be underdosing your patients, otherwise you'll be in a big soup. Similarly, in CRRT, in malnutrition, if you see, there's a depletion syndrome there. Lot of amino acids, selenium, zinc, fat, glucose, everything is removed. So what we have to do, we have to basically replenish them. So that is the reason we do not cut off on our protein levels. So I have to give around 1.7 gram per kg per day if the patient is in a hypercatabolic state. So do not restrict on your proteins. This is very important. We give around 30 kilocalories per kg per day. We know about our fats, about our carbohydrates, but I am telling you about the proteins. Do not restrict on your proteins. Now, the most important question that comes to your mind: by whom? Who will do it? Who will take the call? It's a big dilemma. It's a nephrologist, an intensivist. Who is going to take the call? Because I always face this question from the budding intensivists that can I do a CRRT in my ICU independently? Yes, you can do it. It is in your therapy, it is in your curriculum. Go through this. If you have any doubt, if somebody asks you, we have certain very beautiful guidelines that has been taken out by us, by the ISCCM expert panel. This is a white paper that has been come out. The guidelines that we have taken out, and definitely certain narrative reviews that will come out. You can go through them. The guidelines have been very well written. The whole of the renal replacement therapy will get from renal replacement to renal support therapy. The narrative review that we have written, you go through it. I think many of your questions will be solved. But I always tell that awareness, the eagerness, the good teamwork and coordination, availability of consumables, receptive and encouraging administration, and standard ICU care. This is what is needed to make a CRRT program a success and inspire you to live. Thank you so much for your patient hearing. Thank you. If you have any questions, you can ask me. If you can ask me on my mail, you can ask me on my phone number. And there are many things in CRRT which needs to be discussed, but uh, uh, due to shortage of time, it is not possible, because especially the especially the prescription part. When if because it itself will take around 45 minutes to 1 hour. So I'm not going for it because already 40 minutes is gone. We have some tolerability of hearing basically. So I think I'll stop here. If there are any questions, you can ask me. Thank you so much. Klesh, good
Yeah.
evening.
Good evening, Dada. It's lovely hearing you. You know, one after the other. I mean, I had been seeing you for so many years, and you had been a prolific speaker, and you have in-depth knowledge of CRRT. I think
Thank you
it
so
is
much.
all justice to the topic that has been done. And I was watching and listening to you, and it made me refreshed again with the knowledge about CRRT. So every time you hear and you get to know something new, so that is what is
Thank you
important.
so much.
So basically there are few questions. Can we take the other few questions in the chat box?
Please, please go and take it.
Yeah. So there is one question: can ECOR and CRRT be done simultaneously?
Why
This is
not?
one.
Yes, it is done simultaneously. I showed you the video. CRRT
Yeah.
was going on. Basically, what happens when a ARDS, when it comes with AKI, the mortality increases from 20 to 42.40%. That's doubled. So you can combine both of them together. I showed you the video. Now the new circuits are coming. You can use both of them, or you can also use them individually. There is no problem. Both of them can be done. Yes.
Yeah, there is one more question, Dada, if you can accept. Please
Uh,
enlighten about the filtration fraction. Yeah.
the person who has asked the question, he already knows about it. So
Yeah.
otherwise, you would not have asked about filtration fraction. It's a very good question. Because you must be knowing it, so you are asking it. So we understand, who knows what and who is asking what. So the point is, filtration fraction depends on the rate of ultrafiltration. So ultrafiltrate rate divided by the plasma flow rate. Plasma flow rate is 1 minus hematocrit into blood flow rate into 100. This is filtration fraction. We want to keep the filtration fraction low, below 25%. Because if more filter I do, the more the chance of the clotting of the circuit. So I keep my filtration fraction below 25%. So for that, what I can do? I can either increase the blood flow, which will increase the plasma flow, or I can decrease my ultrafiltration. So moment I crossing 25%, I increase either my blood flow or I decrease my ultrafiltration flow. This is filtration fraction. Remember, if you're crossing filtration fraction due to any situation, and you have to also increase the dose of your antibiotics because you're giving a lot of antibiotics along with that huge amount of ultrafiltration that you're doing. Yes.
Dada, are there any other ways of improving ultrafiltration? Has it something to do with blood flow, or has it something to do with the dialysis? Do you like to throw some light on that also? Because most of the times we tend to keep blood flow as low as possible, and probably the filtration is compromised. Do you think keeping
So
blood flow a little higher will improve the filtration?
yes, definitely. Suppose if you are doing a dialysis, for example, you are doing CVVHD. Now, if we are doing dialysis, there we don't need a huge amount of blood flow because we have to remove the small molecules. Even a blood flow, suppose you are going for 1000 ml per hour. In a 50 kg individual, it is around 20 ml per kg per hour. So 1000 ml per hour means 33 ml per minute. So at least three times, 2.5 to three times of that, 100 ml is enough for when you are going for a dialysis. Moment you are going for ultrafiltration, especially pre-filter ultrafiltration, at least 6 times the ultrafiltration that you are doing per minute, you have to use as a blood flow. For example, 1000 ml per hour of ultrafiltration pre-filter. That means, what is pre-filter? If you are removing that 1000 ml, I am replacing also the same amount before the filter, before the blood enters the filter. This is pre-filter. So if it is 33 ml per minute, I have to give at least 6 times. Otherwise, it will not be working. So at least 165 ml per hour I have to keep. If I'm doing a post filter, for example, I am removing the fluid and replacing that after it comes out of the filter at least 5 times. That means 33 ml into 5. So you have to see this, what you are doing pre and post, if you're combining between 5 to 6 times. So the blood flow has to be kept accordingly. Remember, very huge amount of blood flow also allows the catheter, again, the filter will be at risk. So the blood flow have to be managed accordingly. And this is the way how normally we do it. Remember, when you are doing ultrafiltration, whatever you are removing, you are giving it back. But there is a terminology in the machine called patient fluid removal, or the same thing is known as net ultrafiltration in a different machine. That is basically scuff. You are removing that extra amount of fluid, but you are not replacing back to the machine. So that is basically negative balance CRRT, where you are removing more, but you are replacing less. What is that zero balance CRRT? Whatever you are removing, you are replacing. So now you will ask me why you are replacing. Zarurat kya hai? Why do you replace? Why do you remove? There is no meaning. So we are basically replacing a physiological solution and replacing a pathological fluid from the patient. So pathological fluid is replaced by a physiological solution. This has to be understood.
Oh,
All right.
fantastic. Would keeping high dilysate would also improve the filtration?
Ultrafiltration,
Yeah, if I keep
dialysate
the
high.
dilysate, yeah, if I keep the
No, I
dilysate very
we have
high.
to understand. We have to understand some amount of ultrafiltration also goes on when you are doing about dialysis. For example, you are doing hemotreatment and hemodialysis. Some amount of ultrafiltration also goes off, but
Yeah,
but that is very insignificant. Dialysis
yes.
works by the process of concentration gradient. I increase dialysate rate, the concentration gradient is increased, but not the ultrafiltration which is working by the pressure gradient. Some amount of pressure will be created, some amount of fluids will be removed, but that is not very insignificant. That is insignificant. We cannot depend on them to basically remove that extra amount of fluid from the pulmonary area or from the subcerebral edema. It doesn't make it will not do it.
Oh, fantastic, fantastic. There's one more question. How long the catheter can be used
You keep the
for
catheter as long
dialysis?
as you can. So you have to see the pressures then. You have to see the
Yeah.
access pressure. You have to see the return pressure. We have not discussed that. The access pressure is basically just sucking it out, so it is negative. Minus 52, minus 150. But pushing it, return back, it is positive, plus 52, plus 150. If these pressures are basically varying, that means you have some problem with the catheter. You're basically the catheter itself is getting clogged. Till your catheter is well, the pressures are all right, you could keep your catheter. There is no increase of, if you feel that if you keep it for 7 days also, there is no problem. There is no infection. But go on looking the area as you do in the CBP line. Go on looking into your catheter. If you find any redness, if you find any signs of inflammation there, remove the catheter.
So as long as the catheter is functional and you keep a good
Normally,
hygiene,
normally we do
yeah,
CRRT at least for three
yeah.
to 4 days, so that is enough for the catheter to be functional and to be used.
But we can extend it maybe beyond that as well.
Yes, yes, why not?
If
There
the
is no
infection
further fast
control,
route.
if the infection control measures are well placed,
Exactly,
probably,
exactly.
and you
Regularly,
check
you
the
have to follow your
catheter
charts.
and the
Yes.
patency of the catheter is well maintained, we can keep it as long. People have requested your contact details, Dada. Uh,
My phone number
so,
is 98912 57572. My email is TITIR, T for Tamil Nadu, I for ice cream, again T for Tamil Nadu, A for ice cream, R for Rajasthan, TITIR 2002 at gmail.com. And I am doing my CRRT regularly in my hospital. Those who are in Delhi, you can come and anytime visit my hospital to learn the CRRT and to make me learn also, because when I teach, I also, Akhilesh will also
yeah,
agree with
agree.
me that whenever I
Yes.
teach, we learn. Every day we learn. So we are still
Yes.
in the learning process along with you. Your questions basically
Make us learn.
rejuvenates us. Yes, make us
Yes.
learn. I'll again go and read today. Maybe I'm missing something. My phone number
Yeah.
again, somebody is asking 98912 57572.
Fantastic,
So
Dada. Fantastic.
somebody wants it in the screen. Should I show my screen again?
Yeah, I think you can write in the chat
All right.
box also your number.
All right.
Yeah.
All right. I am showing it in the screen.
Yeah.
If you want, I show it in the screen.
Yeah. So, Dada, there is one more question till
Yes,
people
yes. Yes, yes,
give
please.
your contact number. Dialyzing a patient with severe hyponatremia and
Ah,
hyperkalemia, how do
interesting.
we modify the script? It means they're
Again,
asking about the
again,
prescription for
exactly.
hyperkalemia.
Again, the person who has asked it, I congratulate you because you regularly do CRT. That is the reason you are asking it. Because normally people will not ask if you are not doing it. See, when you are doing, this is a very good question. When you are doing hyponatremia, then you can do two things. Either you customize the fluid, or you customize the circuit. For example, your patient sodium is 110, and your fluid Prismasol is having 140. So now if you do CRRT, if you start hemodialysis, that is continuous venovenous hemodialysis or hemofiltration, there will be a huge correction of sodium from 140 to 110. So normally we do not correct more than 10 milliequivalent per day. We know about that. So there is a calculation for that, in which if you are using hemodialysis, with heparin, I add 10 plus 2. And if I am using citrate, I use plus 4. So if sorry, citrate plus 2 and your heparin plus 4, because citrate again has 3 units of sodium. So whatever it may be, I have to basically, I can show you the calculation here because I would have loved to show it. You have to dilute your fluid, and you have to decrease the sodium level from 140 to something less, maybe up to 124. You have to add that amount of sterile water inside the patient, not 5% dextrose, whatever you want. So you dilute your fluid to decrease the level of sodium from 140 to around 130, 124. There is a calculation for that, and you can do that. It's a very easy calculation. But you remember, when you're diluting it, you're also diluting your bicarbonate. You're also diluting, you have no potassium there in that, so in their fluid. So if your patient is in metabolic acidosis, from 32, the bicarbonate has come down to 29. So you have to add a bit of bicarbonate also there. So whenever diluting your fluid, you have to add on to your bicarbonate to do that. For hyperkalemia, yes, you don't have to do anything because your potassium is zero. It will very quickly diffuse. For hypokalemia, sometimes you might have to add a bit of potassium to the circuit, but what I feel to that fluid, but what I feel, it is better to correct from outside. Remember, CRRT will always land up in hypokalemia, always land up in hypophosphatemia, which you don't, normally you don't measure. You phosphate, you don't measure. So it will land up in hypokalemia, hypophosphatemia, hypothermia. These three has to be there. If you are not using a warmer, you definitely will land up into hypothermia. And or what you can do for sodium, you don't know to do this, you just replace 5% dextrose post filter. There are certain calculations for that. So either I change the fluid or I customize my circuit by giving 5% dextrose post filter, or I customize my fluid by adding on some amount of sterile water or 5% dextrose inside the fluid. Remember, if you're inserting fluid inside your bag, you're also diluting on the other components. That has to be taken care of. Any other question?
Mm. Yeah. How about hyperkalemia? I think he had asked for hyperkalemia. I
I
think
told you that
the answer
your
remains
sodium,
the same.
your fluid does not have any
Yeah.
potassium, so it will get diffused very quickly. So you have to go
Yeah.
for a continuous venovenous hemodialysis, increase your blood flow a bit, and remove the potassium as quickly as possible. But it is much inferior to hemodialysis, I tell you. If the patient is hemodynamically stable, if you're having hyperkalemia, don't do CRRT. Go for hemodialysis.
Yeah. So basically, this hyperkalemia is usually very difficult to treat in patients with
Yes,
rhabdomyolysis, crush injury
yes,
patients. And
yes,
it's really difficult to treat. You try to correct.
very difficult.
CRRT is not really efficient to correct it. Probably
Yes,
CVVSDF we can do with your
yes,
usual 5008 machine, and you can keep very high dilysates, or you can tweak in your filtration components adequately, and you can do proper dialysis. Because if the patient has hyperkalemia, if the hemodynamics are well settled, probably you can do better hemodialysis rather than CRRT. And you need a rapid clearance of potassium, and that is better done with hemodialysis. And CVVSDF is better,
yes.
managing hyperkalemia. I hope you agree with me, Dada. Hmm?
Yes, yes, exactly,
Yeah.
exactly, exactly.
So
We
yes,
should
there
know
is.
exactly where not to do CRIT. That is very
Yeah,
important. We
yeah,
cannot prescribe CT everywhere. There are certain specific scenarios where it to be used properly. A patient, so for example, I give you an example. A patient coming in the middle of the night with full lung, with full of water, pulmonary edema, following PIH, mainly the gynae patients, they come, the after obstetric patients after the delivery, flooded with pulmonary edema. You have no other choice but to intubate the patient, give a high amount of PEEP, and the patient is hemodynamically unstable, two wrist pressures, praying to God, let the blood pressure come up, we start some amount of Lasix. Because Lasix, again, fusimide will be completely resistant in this type of patients. Here, CRRT works wonderfully. You just do scuff, remove that extra amount of fluid, the 700-800 ml of fluid is there accumulated here. Remove it in 3-4 hours. And the patient will having, believe me, the patient will having a cup of tea in the morning.
Yes, yes, yes. Especially
This,
patients with acute kidney
yes,
injury, anuric patient, they will respond rapidly. Where the
very
diuretics
rapidly.
fail miserably. Yes, yes.
Exactly.
And the
And
CRRT also has limitations in the sense that you cannot do high dialysates. We
no,
have
you can't.
limitation, maybe
You can't.
3 liters, 4 liters, maybe maximum
Yes,
6 liters. Or you may have to use two dialysis, two CRRT machines to enhance dialysate. That is not practically possible
no,
in
this
all
is
the
not possible.
centers. So better hemodialysis can be done, and then
Yes.
your
But
ultra.
hemodynamically unstable patient in the middle of the night, you will not have any technician there to start your hemodialysis. A CRRT
Yes,
can be
yes.
started within 12
CRRT
to 20
can be started.
minutes by the residents also. It is life saving.
Sure. Thank you, Dada. Thanks for the insights. There is another question. Using eight femoral vein, you don't think better to avoid because we transplanted on right iliac fossa, so there is a risk of thrombosis. Means using right
Using
femoral
8,
vein, you don't think better to avoid because we transplanted on right iliac fossa. So there is a risk of thrombosis. Means she's
yes,
asking if
yes,
the patient is
yes,
transplanted on the right side, is there a risk of putting femoral catheter
yes,
into
yes,
dialysis?
yes, yes.
Yeah.
Yes, yes, you are absolutely right. There is chance of thrombosis, especially in the femoral veins. The chances of thrombosis are much more. But if you have no other choice, then you have no other choice but to save the patient for 1 or 2 days. You have to do a CRRT. You have every veins occupied. The left internal jugular should not be used. It is having a course which is basically bended course. If you use a catheter there, your CRRT will fail. The flow will not be there. Either you use a right internal jugular or use a right femoral, left femoral. So that is the situation. If you have that type of situation which you are telling, then I remove my right internal jugular, use my right internal jugular. Most of the times we'll try to do it in the right internal jugular. If I don't get it, I go for a femoral, I'm telling. It is not
Perfect.
that I'm telling you go for a femoral. Go for a right internal jugular. Not getting it, put a line on the left internal jugular if you want this CVP line, and go for a right internal jugular. No problem. You can go for it. You have so many options. Yes.
Oh, fantastic, fantastic. Why to use in the same site if you have other access available? It's only in the life-threatening situations where you don't have any access. Probably then you use right femoral where the transplants have
Yes.
been done,
Yes.
and
Yes.
probably you can avoid. Yeah. So there is one more question. Contraindications for CRRT. Uh, Patient refusal, finances. Apart from that, anything else? If the patient is
So
hemodynamically
patient is
stable.
hemodynamically stable, and the patient is sitting in your ICU, and the patient is having a high urea slowly going into obtundation. Don't use CRRT. Use the other form of therapies. Contraindication, obviously. In that way, CRRT, we should. I was telling you not to use CRRT. Yes, price is a big contraindication, but I can use CRRT. Believe me, in our Indian scenarios, I can do it within 5,000 rupees per day. We know how to do it. So those who knows how to do it, they can visit a much lesser price than what's been used. One antibiotic cost you how much? Around 6,000 rupees per vial. Many antibiotics. CRRT for 5. You don't have to use CVV HDF always. Use your own fluid. We know how to make our own fluids. We can use our fluids, and we can cut off on my price. I can use my sets for 3 to 4 days very effectively. So it comes down to around 3,000 rupees per day. So one of the relative contraindications of it is the cost. Finances is very important. And those where you are having a severe hyperkalemia, patient hemodynamically stable, don't use CRRT.
Yes, yes.
So
Thanks.
you have to understand the limitations. CRRT is only to be used only in the sickest of the sick, where the
Yes,
patient is
yes.
severely hemodynamically unstable with severe volume disturbance. There is the patient who have to use CRRT.
Yeah, there is one more question, Dada. This is very pertinent question somebody has asked. Uh, if the patient requires CRRT in emergency, before starting CRRT, nephrology opinion is required.
I don't think so. You start your CRRT. I am doing it regularly. If your curriculum is having a CRRT or an expert in CRRT, you are doing CRRT for the last 10 years, or you are trained in CRRT, especially us intensivists now are trained in CRRT. It is in our curriculum. When you are curriculum, do you have to, when you're in the emergency to give a shock, do you call the cardiologist? I'm just asking you. The question that you have asked me to give a DC shock, do you call a cardiologist? Let the cardiologist come, I'll give a DC shock. Is it there?
So I think,
Indian scenario is very clear. If you have an expertise in the subject, even with an MBBS degree, you can do anything.
oh yes,
So don't
yes.
worry. Don't worry.
You,
And we have
yes.
already come up from the ISCC with the white paper where we can use, where we can't use. This is my opinion. It's up to you in what scenario you are working. If you have a nephrologist by the side, in the middle of the night at 2 o'clock in the nephrologist, if you have it, you are most welcome to call it. There is no problem.
Sure, fantastic. It's always a coordinated approach, and probably
Exactly,
you need to
exactly.
take a lead.
It's not about a
And what is
nephrology or an
important for the
intensive.
patient in the situation where the patient is presenting with life-threatening complications.
Exactly.
So probably you can take the decisions. As you rightly said, while shocking the patient, you don't call a cardiologist how to shock and all that. Similarly, you don't really need to call, but you keep them updated and you take a formal reference for
Next
that.
day you
And
discuss with
next
him.
day,
Next day we
next,
discuss with him. Let him come. Let him give
yeah,
his inputs. Let us
yeah.
sit together, have a cup of tea. Let him write his notes. What's the problem?
Oh,
But
sure,
start it
fantastic.
immediately if you need.
Yeah, you don't delay till the nephrologist come next
Exactly.
day, and
Exactly.
you delay CRRT for
By the
months.
time you have lost your patient,
Yeah, fantastic. Really. So, is there any cutoff of blood pressure before initiating CRRT? So, I think there is
nothing.
no
No
cutoff
cutoff
as
of blood
long as the
pressure.
patient is tolerating. But you can, if the patient is hemodynamically unstable, you can add vasopressors, you may give fluids, or you try to keep the mean arterial pressure above 65 and initiate CRRT. And once the acidosis is corrected, sometimes the fluid overloaded patient, if you remove the fluid, the patient improves dramatically. So it is all individualized approach. What is important for your patient, you can take into consideration what is required, and probably you can tweak in with the different settings of the CRRT. Yeah. So Dada, there is one more question. Is hemodynamically stable DCLD, decompensated liver disease patient, is CRRT better than SD for ammonia removal?
CRRT has been used for ammonia removal, especially you have to go for ultrafiltration there because here we have to go for a high dose of ultrafiltration. I told you for 50 ml per kg. We use for CRRT here I uh, I have seen people using, especially in decompensated liver disease patients, CRRT used as a bridge therapy between liver transplant and these patients. It is not only about removal of ammonia; it is also to take care of the acidosis. It also take care about the fluid overload. It is a combined thing that is being used by CRRT. Hemodialysis takes a part of it. Is definitely ammonia can be removed by hemodialysis, small molecule, but there's a rebound phenomenon in ammonia. Comes back after 4 5 hours. By the time you have stopped your hemodialysis, the rebound phenomenon comes back, ammonia rises. So this redistribution that occurs, so that the CRRT, which is slow, continuous process, can take better care of ammonia than the other modalities.
Yeah, because ammonia is really difficult to really control with
Exactly.
hemodialysis,
Exactly.
and you struggle again, you dialyze, and again patient deteriorates after some time. That's why you need a continuous removal of ammonia, and that is feasible only with CRRT. So that was well justified, Dada. There is one more question from the audience, and then we can wind up the session. Uh, how often do you have to give inline anticoagulation, especially if the patient is having coagulopathy?
I don't get how inline anticoagulation means. Which one do you
So
want?
probably she must be talking about regional anticoagulation. Do we really need to give a regional anticoagulation when the patient already has coagulopathy? So probably if the patient already has a coagulopathy, the chances of filter clotting will be reduced. But yes, there are situations, even if the patient has coagulopathy, they have thrombotic phenomenon which goes on, especially in patients with DIC. Regional anticoagulation may be recommended, especially citrate anticoagulation can be offered to these patients in order to increase the shelf life of the filter, and you can prolong the duration of the CRRT, and the filter life can also be increased. I think this is the answer that I can justify. Dada, if you want, you can also add on this.
Oh no, you are absolutely all right. Because even if because patients in the prothrombotic stage, you have a chance of filter clot, so you have to use. So this is. I just want to qualify this a bit. So if you really want to see what stage of coagulopathy you are. So need dynamic that is coagulation measurement for that. If you have a thromboelastogram in your ICU, then you can see exactly in which stage you are. For example, you're the hyper consumable stage. So there, anticoagulant will work better. You have in a stage where already the graph is coming very, very, very thin. That means you have all the coagulation factors have been consumed. So there you don't need any anticoagulant. So you can use your thromboelastograms well to judge exactly what to do. Remember, if you're using citrate, and in India, the two forms of citrate can be given. ACTA citrate, if you are giving, that is in a less volume. But if you are using a bag of citrate of 5 liters of citrate, lot of fluid has to be given pre-filter. That decreases the efficacy of the CRRT a lot. So that also has to be kept into account when you're using citrate as an anticoagulant.
Oh, fantastic, fantastic, Dada. I mean, but there are centers where the thromboelastogram is not available. I
Yes.
think routine PT-INR
Yeah.
monitoring
Yeah,
and
regularly go for PTINR and PTT monitoring, though I say
platelets
that
may
PTINR,
not be a reliable tool. Yeah,
exactly.
but
Because
but
if you're
when
using
when you don't have
hyperinflation,
options, when you
yes,
don't have options, I think we can use
yes,
routine coagulation parameters to assess
yes.
the stage of coagulation, and we can go ahead. Yeah, I think we are done, Dada. I think audience all their questions we have tried to answer, and
I have, I think I have tried to answer most of the questions, both of you and me,
yeah, yeah,
and there will be if you have still any queries, you can anytime call us. Dr.
yeah,
Akhilesh is there in Mumbai. If you're there in Mumbai, you can come there. We're there in Delhi. We are always here. And
yeah,
definitely many of you must be going in Kochi also. I don't know, many of you are from outside India,
uh,
so we can meet you in Dubai somewhere, maybe in Bali. So let us see where,
yeah.
and we can do a CRT course there.
I hope
Thank you so much.
you are coming for the Kochi
Yes,
renal
I'm coming on
replacement
4th.
therapy workshop.
Yes, I'm coming there. Yes, I'm coming there.
Oh, fantastic! Looking forward to see you, Dada. It was
Thank
really
you.
a
Thank you,
privilege and
Akhilesh.
honor to have you with us on this platform, and
Thank
probably
you.
the audience would have loved to listen to you. And hoping to see you again and again on this platform. Knowledge sharing is one of the important and very noble, work that we actually end up doing it. But at least there is a selfishness behind. Basically, when you teach, when you preach, probably you are learning simultaneously. So it means your learning has not stopped anywhere. As you said again in your previous slides, also you said that learning doesn't end. It's every day teach you something new. So that with this thought process, I think we can wind up the session. We can request the academy to wind up the session and conclude the session now with their concluding remarks. If there are no one, I think we can conclude this session. Bye bye for now, and looking forward to see you
Thank you
again.
then.
Good night. Good night. Good
Thank
night.
you. Good night. Good night.
Thank you,
Thank you so
sir.
much.
Thank you, Ranjit, sir. Thank you, Akhilesh, sir.
Yeah. Thank you. Bye bye. Good night. Good night.